So I hope you're clear about the life cycle. If you have any more doubts, you can go back to that slide which showed the life cycle. Now let us look at the epidemiology of this disease. So it is a very severe disease. It affects almost 200 million people the world over, and each year we lose 1 million people due to malaria. So this occurs mostly in tropical and subtropical countries, and obviously after the monsoon. So any amount of rain, small or big, is going to allow mosquito breeding. So obviously it is a problem of the tropics. And for people who come in contact with malaria for the first time, it might not be obvious immediately. Okay. So once they go back, it might take some time, as long as 3 years, for the disease to manifest in such people. So if you thought mosquito bite was the only way malaria can be transmitted, you're wrong. So there are other ways by which malaria can be transmitted. One is through the placenta. So from mother to child, it can happen, and it can be through blood transfusion and also through IV drug abuse. Okay, so this is just like any other blood-borne disease you have, just like you have your HIV and all, the same thing can happen with here mosquitoes and addition, right? So what is the pathology? Pathology here, like I said, is largely due to the destruction of RBCs. You see there, isn't it? Each time there is a cycle, the RBCs are rupturing. So obviously there's destruction of the RBCs. That means you will have anemia. Okay. And once you have broken down RBCs, if you remember your pathology, what is going to happen to all the destroyed RBCs? It is the job of the spleen to separate them out and lyse all the broken down RBCs, isn't it? So what do you expect because of this? So the spleen is going to filter a lot of this. So it is being burdened. So naturally, you expect to see splenomegaly, isn't it? So you will have splenomegaly because of this. So please remember, anemia you see because of destruction of RBCs, and because of release of merozoites and lysis of the RBCs, you will see the spleen doing a lot of work, which is why they have to keep filtering constantly all these ruptured RBCs. They will be enlarged. So this is a look at the world malaria map, you can call this. As you can see, we have a lot of endemic region down south as well. Okay. So Karnataka, some parts of Kerala and some part of Tamil Nadu, and also the upper North Indian belt. So you have Orissa here, and in addition you have in Uttar Pradesh, West Bengal. So as a country, we have not been able to eradicate malaria. Okay, so very much present in our country. You have people dying because of it. So this is an ever-present problem in our country. And also other parts of the world, as you can see, the yellow and the red regions. So the countries which are in grey are the ones who've never had malaria, or it has been eradicated, or it has disappeared, largely due to better sanitary conditions. Okay, so which of the four, which is the worst of the lot? It's falciparum that you need to be really worried about if you get infected. Why? Because it causes the most severe form of malaria. Okay, so this includes hemorrhage and necrosis in the brain. It is the same thing that is happening. So there's destruction of RBCs. Okay, so there is hemorrhage in the brain, there is necrosis in the brain, and there's extensive hemolysis as well. Once you have breakdown, you have to remember the kidneys, the spleen, everything has to filter all these, isn't it? So even it lands up coming into the urine. So once there's breakdown of RBCs, you will have hemoglobin floating around in the blood from this, and it gets filtered in the urine as well. So which is why we call it as black water fever. So if you have hemoglobin in the urine and you expose it to air, so you have oxygenation, so it turns black, isn't it? This is something you all have learned already in biochemistry. Just a brush up on that. So does it mean everybody is going to land up? So for people with sickle cell suffering a lot, that is one trait that helps them to survive against malaria. Okay, because the RBCs as such are compromised in sickle cell, they're not able to produce sufficient ATP to support the parasite growth. Okay, so excuse me. People with sickle cell, patients with sickle cell are protected in a kind of backhanded way. Then you have Duffy blood group antigen. This is a receptor for Plasmodium vivax. That means, so people who have Duffy group are more prone to getting vivax, and people without Duffy group blood group antigen are resistant to vivax. So, which is why 90% of the black West Africans, that's a very politically wrong term, that is West Africans are resistant to Plasmodium vivax. So also carriers of G6PD deficiency are protected against severe effects of falciparum. So you can see nature has a way of balancing out these individuals who already have an issue and they are protected. So what are the clinical findings? How will you have a patient of malaria presenting to you? Like I said, the first sign is that of fever. Remember, RBC is breaking down, releasing what are they releasing? The merozoites, isn't it? They're releasing the merozoites into the blood from the schizons. So that is what is going to cause fever. Okay? And so, in addition, in case of Plasmodium falciparum, they would have headache that indicates it has reached the brain. So, there's hemolysis occurring in the brain. Then you have myalgias because again, there's breakdown everywhere of RBCs. So, this would cause myalgia and arthralgia. This is takes about 2 weeks after the mosquito bite. Okay. It takes several days for this periodic pattern of fever to develop. Like you say, you have quartan, tertian malaria. Okay, that will come to that in a bit. What is special about this fever? The fever spikes. I'm sure none of you have taken temperature. So if you have taken with the digital, please find out how much Fahrenheit it comes up to. 41 degrees centigrade is what is the fever is going to rise up to. Okay, and this is accompanied by chills. Okay, because patient is going to have drenching sweats, nausea, vomiting and abdominal pain. So these are your eternal pharmacology favorites. Please remember them in addition to malaria as well. A spike of fever of up to 41 degrees centigrade with chills, nausea, vomiting and abdominal pain. This is followed by drenching sweats. So after having that high fever, patient is going to come down with chills and sweats. Okay, but in between this, the patient is going to feel very normal. Okay, so that is the specialty of malaria, the clinical features. So a fever followed by, just a minute please, excuse me. Yeah, sorry about that. So, like I said, spleen is doing a major amount of work. You expect to see splenomegaly in most of the patient and mild hepatomegaly in about 1/3 of patients. Okay, so splenomegaly is a must. So, when you're examining a patient of suspected malaria, you have to do an abdominal examination, look for spleen, record how much of the spleen is palpable, and also you should record hepatomegaly, how many centimeters. Okay, that is a must. So what happens if you don't treat falciparum malaria? You will simply lose a patient. Okay, because there's extensive brain damage, there's extensive kidney damage, and the other malarias don't cause so much of a fatality as compared to falciparum. Okay, falciparum, you have to worry, you have to treat quickly, you have to be very fast in starting treatment. So are the other malaria very good to human beings? No. Why? Because OVL and Vivax, we will talk about Vivax only here, it can cause relapse of fever several years after the original infection. So here I must tell you, my father, who used to be a medical officer, used to work in Kolar, which is endemic to a lot of infectious diseases like JE, malaria, dengue, everything. So having worked there years after he left service, okay, for about 10 years or so, he would get this relapsing fever, okay, with chills and rigors, okay, high fever. So this is mainly because of the hypnozoids of Vivax, okay, which are present in the liver. So the liver is hiding all of them, and periodically they can come out and cause a relapsing of this fever. Now, how do you diagnose this? So how do we diagnose is based on GIMSA stain, okay? Or we here in our lab, we don't do GIMSA, we do Leishman stain, just like what you do for a peripheral smear in pathology, the same thing we do. But the difference is that you use thick and thin smears. In peripheral smear, you do only in pathology, you do only a thin smear. So why do we do a thin smear and a thick smear? There's a reason behind it. When you do a thick smear, basically what you do is if you see a slide, it's a rectangle, isn't it? At one corner, we drop one drop of blood. Then adjacent to it, about a centimeter away, we drop another, and then you draw the slide, isn't it? To make a you make a thin smear. The reason is it's easy. We use a thick smear to screen for the plasmodium. Okay. So it's easier. What we do is we add a drop of methyl alcohol to the thick smear, and we break down the RBCs. Okay, so it's concentrated. The drop is concentrated. It breaks down the RBCs, leaving behind only any parasites if they're left. So any plasmodium is left, that will be seen very fast, and we are seeing a thick concentrated part of the smear to look at it. So that's how it helps us identify faster in a thick smear as compared to a thin smear. So it tells us, thick smear tells us whether plasmodium is there or not, whereas a thin smear it helps us differentiate the different species of the plasmodium. So you look for schizons, you can see gametocytes. Based on that, you say which species is infecting. But thick smear, if you are in a hurry and you want to tell, they're asking us whether it's malaria or not, it helps us look at it. So this is a picture of Plasmodium falciparum. You can see here these ring forms. These are ring forms, okay? The pointer, the cursor is, this is a ring form of the parasite. So this is slightly larger. They're becoming larger here. I hope you can appreciate this. This is from a GIMSA stain, not from a Leishman. This laboratory diagnosis, Dr. Prakash will continue with this tomorrow, but I'll just give you a fair idea what exactly should one do. Okay, most important, how to diagnose. Before even a lab diagnosis, what you should do is you should examine the patient, record his temperature, ask him how often is he getting this fever. Okay, so that will be a basic examination. Don't think taking temperature is a nurse's job, which they are doing anyway, but you need to know how much. So how much should the temperature be? 41 degrees centigrade, as high as that. Then you're also going to ask them if they have chills and rigors. Okay, so that is also an important diagnosis. It gives you a clinical clue that your patient might be suffering, and you have to check their surroundings, whether rather you have to remember the weather patterns are also important. So if it has rained recently, you should think of dengue, malaria, and J. Okay, if it's an endemic area. So then we are going to use a smear, a thick and a thin smear, to identify whether they are. So if there are gametocytes of falciparum, you're going to see banana shaped gametocytes, whereas the gametocytes of other species are more rounded. And if you see more than 5% of RBCs are infected, it usually indicates falciparum. Okay. Now coming to treatment. I think I will leave treatment to Dr. Prakash. Okay, tomorrow he's going to come and give you in more in detail about laboratory diagnosis, treatment, and prevention. So what I will do instead is go back to the first slide. I want you all to draw a flow chart of the life cycle of malaria from this slide. This is important because it comes as a main question. I know you can't draw artistic diagrams of this, but all of you please write down. Start from here. Write mosquito in English. Spell it, make a box, and write another box here. Write sporozoite here. If you can draw it, it's not very easy. It's not rocket science. Then you can write liver cell. Okay. Please draw this life cycle. I will give you about 10 minutes to draw this. And I want you all to scan your handwritten life cycle and mail it to the mail that you're supposed to send your assignments. Okay, this in addition to the questions that will be given to you, this is a must. Okay, so 10 minutes to finish this. The time starts now, it's 11:41. That completes the class for now. Dr. Prakash will continue the class, next class on Plasmodium. Thank you. So all get ready, well prepared for internal assessment. So your wish is granted, everything is on, theory is on Google Forms and the practicals will be on Zoom app. So the same portions, systemic bacteriology for theory and practical. So clinical applied exercises, whatever were told for you, will be the portion for your uh, practicals along with Z and stain also will be assessed with Viva as well. Thank you.